Today we delve into a very important topic in the field of pulmonary medicine, nebulization and nebulized therapies in pulmonary diseases. As we are all aware, respiratory diseases have become increasingly prevalent in our society, and effective treatment modalities are the need of the hour. To enlighten us on this critical subject, we are honored to have with us Dr. Vatsal Gupta, a highly accomplished expert in the pulmonary medicine. Dr. Gupta is a DM in pulmonary, critical care and sleep medicine and currently serves as a consultant pulmonologist at City Superspeciality Hospital, Gorakhpur. His expertise in this field and vast clinical experience make him the perfect guide for this topic. Before we begin, it's my privilege and honor to introduce today's esteemed speaker, Dr. Vatsal Gupta. Dr. Vatsal Gupta, he holds a DM in pulmonary, critical care and sleep medicine from prestigious AIIMS, Patna, an MD in pulmonary medicine from renowned BP Chest Institute, Delhi, and a DNB in respiratory medicine. So Dr. Gupta's academic contributions are equally impressive, with 14 publications in various national and international journals. These reflect his commitment to advancing research and knowledge in pulmonary medicine. So today he will enlighten us on the crucial topic of nebulization and nebulized therapies in pulmonary disease, a subject of great importance in the management of respiratory illness. So let us all warmly welcome Dr. Vatsal Gupta with a big round of applause. Dr. Vatsal.
Good morning, everyone. Thank you, sir, for the kind welcome. And I would like to thank the GP Association of Gorakhpur for providing me an opportunity to speak on this platform. And my topic for today is nebulizers and nebulized therapies for pulmonary disease. So, what are nebulizers? Nebulizers enable conversion of liquid drug formulations into inhalable emitted aerosols that can be deposited in the distal lungs. So, these aerosols which are produced, their size varies. So, the larger size aerosols get deposited in the proximal airways, and as their size reduces, they reach up to the distal airways. So, the aerosols in the range of 10 to 30 micrometer, they are deposited in the oropharyngeal region. Aerosols in the range of 2 to 16 micrometer get deposited in the conducting zone of the airway, that is the trachea, bronchi, bronchioles and the terminal bronchioles. And the aerosols which are less than 2 micrometer in diameter, they only reach the respiratory zone or the respiratory bronchioles, alveolar ducts and alveoli. So, the appropriate size of the particles which are generated by these nebulizers is of utmost importance for effective delivery of the drug. So, there are basically three main type of nebulizers. First is the jet nebulizers, second is the ultrasonic nebulizers, and third is the mesh nebulizers. So, the jet nebulizers, they make use of a compressed gas to make an aerosol. The ultrasonic nebulizers use high frequency vibrations to generate aerosol. And the third is the mesh nebulizers, which uses vibrations along with a fine mesh through which the liquid passes to form the aerosol. These are pictorial representation of all the three types of nebulizers along with their graphical representation. So, first is the jet nebulizers. These are the components of a jet nebulizers. There is a nozzle for compressed gas which passes through this. There is a chamber which contains the liquid, and there is an output for the aerosol which is produced. So, the compressed gas creates a difference in the pressures through which the liquid is converted into aerosol and it passes through it. The baffle present here prevents the particles of larger size so that it comes back into the liquid and it again gets aerosolized. The second is the ultrasonic nebulizers, which makes use of a piezoelectric element which vibrates at very high frequency when connected to an electric source and converts the liquid into aerosol. Third is the mesh nebulizer, which consists of a piezoelectric crystal along with a mesh which is in contact with the liquid, and through this the liquid passes and it gets converted into aerosol. So, now we will see each of them one by one. So, the first is the jet nebulizers, which are the most commonly used and has been in practice from many years. It utilizes 2 to 10 liters of pressurized gas for its work. if a compressor is not available, instead of a pressurized gas, we connect it directly to the oxygen supply of the hospital. So what it can do, it can deliver bronchodilators, corticosteroids, antibiotics, mucolytics, liposomal formulations, recombinant products. Basically, you can deliver everything with the help of a jet nebulizers. But the problem lies with it that it has inefficient drug delivery. So the image shows various parts of a jet nebulizers. This is a compressor, this is a corrugated tubing, this is the medication chamber, this is the face mask for adults, for child, and this is the mouthpiece. This shows the way how these nebulizers can be used in adults, children, and pediatric population. So we saw that jet nebulizers has such inefficient drug delivery. So various modifications have been made in its design for efficient drug delivery. So the first one which we saw previously was a jet nebulizer with a corrugated tube, which we saw in the previous image. This is the corrugated tube through which the jet nebulizer is connected. So what it does, it generates continuous aerosol during inspiration, expiration, and breath hold. So because of the continuous generation, there is lot of drug wastage in the process. So the first modification which came in this was a to use the jet nebulizer with a collection bag. So what it does is releases aerosol during inhalation. The aerosols which are generated during expiration are stored in a collection bag and given to the patient during next breath through a one-way valve which is located between the mouthpiece and the collection bag. So this image shows how it works. So this is the, in a way, collection bag, this is the mouthpiece. So the aerosols which are generated during expiration are stored in this, and then they can be taken with the next breath. Then next came the quality of breath enhanced jet nebulizers. So these nebulizers are also intended to reduce the ineffective drug delivery. So they generate aerosols using a negative pressure created by patient's inspiratory effort. More aerosol is generated during inhalation through one-way valve in the mouthpiece. So in this also, although the aerosol is generated all throughout the process, but more aerosol is inhaled during the process of inhalation. These are breath enhanced nebulizers. And the last one is, which is the most advanced in this, is the breath actuated jet nebulizers, which sense the patient's inspiratory flow and deliver the aerosol only during the process of inspiration. So these nebulizers in a way are most effective because they reduce drug wastage in maximum proportion, but the time taken by these nebulizers is more compared to the other type of nebulizers. So that we can see in this graph that only during inhalation the aerosols are produced. So these are the examples of certain advanced jet nebulizers, breath enhanced jet nebulizers, which comes by the name of Pari LC Sprint. The other is a Side Stream Plus. Then there are breath actuated jet nebulizers, also called as BAN. So it comes by the name of Aero Eclipse 2. At present, these nebulizers are not present in India. They have to be acquired from other countries. So next we see is the ultrasonic nebulizer. Ultrasonic nebulizers incorporate a piezoelectric crystal which vibrates at high frequency in order to produce aerosol. So they are of larger volume and smaller volumes. Larger volumes basically are used for delivery of hypertonic saline for sputum induction, and small volumes are used for delivery of inhaled medication. These are also not much popular in practice because of their high cost. This Omron ultrasonic nebulizers cost around 35,000, and the limitations of this are there is large residual volumes. It cannot aerosolize viscous solution. It degrades heat sensitive material, and it should be avoided with suspensions and proteins. So the most advanced nebulizers which can be used in practice are the mesh nebulizers. So what it does is it forces liquid medication through multiple apertures in a mesh or an aperture plate in order to generate aerosol. So these are active nebulizers or passive nebulizers. So active nebulizers contains a piezo element that contracts and expands on application of electric current and vibrates a mesh in order to generate aerosol. And passive vibration, it is battery operated device which uses a transducer horn which has multiple holes to produce aerosol. Now we see one of the examples of active mesh nebulizers, which comes by the name of ArrowNeb, which is produced by the company named as ArrowGen. So the advantage with these nebulizers are that it can be used for both spontaneously breathing and even ventilator dependent patients. So the various varieties of it is, first is ArrowNeb Go, which is a portable compact handheld nebulizer. The ArrowNeb Solo, it can be connected to both ventilator, that is by invasive mechanical ventilation, or non-invasive ventilation via BiPAP or high flow nasal cannula. The ArrowNeb Nevo is used for aerosol delivery during non-invasive ventilation. All of these nebulizers can be assembled easily. They have a silent operation and a short treatment time and are easy to clean. The image shows an example of two of the active mesh nebulizers. First is an ArrowGen Solo. This nebulizers can be connected to both invasive and non-invasive ventilation. This is the medication chamber, this is the piezoelectric crystal, and this has to be connected with a power source. This is meant for use in a single patient, that's why the name ArrowGen Solo. The next is the ArrowGen Pro, which can be disassembled and cleaned and can be used in multiple patients. This comes by the name of ArrowGen Pro. These are in a way one of the best nebulizers, but the problem with this is the cost goes in lakhs. Now this is the image of how these ArrowGen nebulizers works in a closed circuit system. So this is the ArrowGen Solo, which makes a closed circuit and enables efficient delivery of the drug to the patient who is on invasive mechanical ventilator. We also saw that even jet nebulizers or pressurized MDIs can be used for the process of drug delivery for patients on invasive ventilation, but there is a lot of wastage of drug due to breakage of the closed circuit. Now the next variety of mesh nebulizer is a passive mesh nebulizer, which comes by the name of portable micro air. This is a micro air nebulizer. This is a battery operated passive mesh nebulizer. The advantage with this is it does not cause any denaturation or inactivation of particles, which the problem was with the use of ultrasonic nebulizers. But the limitation is it is expensive and hard to clean. So this also comes with directly mouthpiece, which can be used by adults, and with the help of a face mask, which can be used by a pediatric population. The next variety of nebulizer are the smart nebulizers. So what are smart nebulizers? They employ adaptive aerosol delivery technology. That is, it adapts to the patient breathing pattern in order to determine the timing of aerosol drug delivery during inhalation. What they do is they analyze the pressure changes of the airflow during the first 3 breaths in order to determine the correct starting point for the drug delivery. So based upon the previous 3 breaths, they alter their breathing, alter the aerosol delivery so as to reduce the drug wastage. One of the examples of a smart nebulizer is an iNeb, which is prepared by Philips Respironics, and it is a small, lightweight, battery powered and silent nebulizers that combines the mesh technology along with adaptive aerosol delivery. So in total this image looks like this, and it has the following parts: the mouthpiece, the chamber lid with the mesh, the medication chamber, and the body. So we can see it is such a portable device and can be carried by a patient in its pocket for effective nebulization delivery. So this is a table which shows a comparative analysis of all the different types of nebulizers which we saw till now. The first is a jet nebulizer with a corrugated tubing, which is the most commonly used nebulizer in practice. It is cheap, easy to use, and enables most of the drugs which cannot be delivered by a pressurized meter dose inhaler or dry powder inhaler. But the disadvantages are it is inefficient, difficult to clean. We need a compressor for delivery of the gas and additional tubings. Another variety of jet nebulizers, that is the breath actuated and the breath enhanced nebulizers. They enable drug delivery only during the process of inhalation. They are easy to use with less wastage of medications and are way more efficient than the above mentioned nebulizers. But the problem with this is they need longer time for drug delivery. They cannot be used with the ventilators and are more expensive. The ultrasonic nebulizers are easy to use and more efficient than the jet nebulizers, but They have large residual volume, they cannot aerosolize the viscous solutions, and they degrade heat sensitive material. The most advanced, the mesh nebulizers, these are fast, quiet, portable. The passive nebulizers are battery operated with a self-contained power source. They have optimal particle size for specific drugs, more efficient and easy to use. The disadvantages are it is more expensive, the cleaning can be difficult, medication dose has to be adjusted when switching from jet nebulizers because of its very efficient drug delivery, and it is also not compatible with viscous liquid or solutions that get crystallized. Now, the second part of this talk, what are the various available nebulized therapies for pulmonary diseases. So, which patient needs nebulization? In a way, any patient who comes to us in OPD, we should never start him on nebulizers first. If patient is able to take a pressurized meter dose inhaler or a dry powder inhaler, always give some time to him and try to teach him that advice. Patients basically with extremes of age, that is pediatric population maybe less than 6 years, and elderly patients who are unable to take inhalers, they can be shifted to nebulization. Apart from that, patients who cannot generate adequate peak inspiratory flow rate, that is of up to 60 liters per minute, which is required for a dry powder inhaler, they need nebulization. Patient with altered neurological status, rheumatological condition, and with coordination issues, they need nebulizers. So, next is what are the advantages of nebulized therapies? How is it better when compared to an IV medication? So, what nebulized therapies does is helps in the delivery of the drugs directly into the respiratory tract, so that higher concentrations can be achieved and lesser side effects of the medications are present. So, these are the various classes of drugs which have been used for many years for nebulization treatment. The various drugs include the bronchodilators, next is the inhaled corticosteroids, antibiotics, mucolytics and prostacyclin analogues, which are in practice for various indications. Now, we will see some of the common respiratory diseases where these nebulizers have a role. So, first is a COPD, that is chronic obstructive pulmonary disease. So, here there is role of SABA and SAMA. SABA are short acting beta agonists, SAMA are short acting muscarinic antagonist. So, various examples include albuterol and levoalbuterol, which we know by the name of salbutamol and levosalbutamol, and SAMA, the example is ipratropium. So, what this does, it improves the FEV1 in COPD patient. The combination of SABA and SAMA is better when compared to individual drug used alone. Apart from SABA and SAMA, there is LABA, that is long acting beta agonist. These are twice daily therapies which are used for maintenance treatment in COPD. The various examples are nebulized R-formoterol and formoterol. Now, even once daily therapies are available with the name of vilanterol. Next is the nebulized LAMA, that is long acting muscarinic antagonist, which comes by the name of glycopyrronium, which is twice daily inhalation. Another drug which is available in once daily formulation is revifenacin. Then there is no role of nebulized inhaled corticosteroid. The gold guidelines for COPD says to start treatment with LABA ICS in a patient with absolute eosinophil count of more than 300, and patients who do not maintain, who are persistently exacerbating or dyspneic on LAMA and LABA therapy may be switched to triple therapy with LABA, LAMA and ICS. There is also role of nebulized antibiotics in COPD patients who are basically chronic pseudomonas colonizers. So, the drugs which are available for this is nebulized tobramycin, nebulized gentamicin, colistin and even levofloxacin. Phosphodiesterase 3 and 4 inhibitors by the name of RPL 554 are also being developed for maintenance treatment of COPD and also for acute exacerbation of COPD. Next is asthma, which we most commonly encounter in our day-to-day practice. So if an asthmatic child who is not able to take inhalers or DPI, for immediate relief, SABA and SAMA can be used alone or in combination. For maintenance treatment, the most effective drug which should be used for long-term control is an ICS, that is inhaled corticosteroid. Its example is budesonide. Then an inhaled LABA, long-acting beta agonist, can be used. The example is arformoterol, which comes by the name of LABA-NEB. A combination of LABA and ICS is used, and if a patient does not respond to LABA ICS, a LAMA by the name of tiotropium or glycopyrronium may be added. Now next condition is bronchiectasis. Bronchiectasis is an irreversible dilatation of airways. The basic funda of management in bronchiectasis is effective airway clearance. There is lesser role of antibiotics or inhaled corticosteroid. So for effective airway clearance, you need nebulization with isotonic saline, hypertonic saline, mucolytics which break the mucus into thin secretions by the help of NAC, that is N-acetylcysteine. Bronchiectasis patients who are chronic pseudomonas colonizers, there we can use colistin and tobramycin. Patient who has breathlessness, there is a role of ipratropium and salbutamol, that is SABAs and SAMA. Even in cystic fibrosis bronchiectasis, these medications have a role. Next is pneumonia. So pneumonia, nebulized antibiotics alone have a questionable role in the management of VAP. They are used along with intravenous antibiotics for the management of VAP. The various options which are available for the management of pneumonia is gentamicin, amikacin, tobramycin, colistin, vancomycin, ceftazidime and levofloxacin. There is also role of antifungals in the management of pulmonary aspergillosis in AIDS patient or post-lung transplant patient, and inhaled pentamidine therapy is used for the prophylaxis of pneumocystis jirovecii pneumonia. Next is non-tubercular mycobacterium, where there is a role of inhaled amikacin or liposomal amikacin formulations. There are now new evolving therapeutics of the role of nebulized therapies for vaccines and gene therapy, for antibodies and also for alpha-1 antitrypsin deficiency. So that's all. Thank you for your patient listening.
I think that was an excellent, insightful and comprehensive presentation. After this quiz, we'll have a question answer session, right? So which type of nebulizer is the child using? Is it jet, ultrasonic, mesh or smart? Raise your hand.
Yes. Dr. Malik. क्या बोले? First one.
ठीक है सही.
Oh, that's great. Jet nebulizer is the right answer. So कैसे बताया आपने, कैसे डिटेक्ट करते हैं jet nebulizer है या?
So in this image we can see that this is a compressor, the white thing. There is a corrugated tubing, the medication chamber and a face mask which the child is using for effective aerosol delivery. So this is the with the compressor we can detect this nebulizer.
Which type of nebulizer is shown in ml? Jet, ultrasonic, mesh and smart. From that side, from that side. Mesh. Is it the right answer? Yes. Big round of applause for the right thing. Mesh nebulizer. So just explain.
So this is the
why this is.
So this child is on invasive mechanical ventilation. We can see an ET tube and also a nebulizers which is in circuit with the ventilator, which is not shown. This nebulizer is an aerogen solo nebulizer which I showed in the picture. The medication is poured from the above and this is in line with the ventilator circuit for effective nebulization delivery.
Are these available in India?
Yes sir, this is we are using in our hospital, this nebulizer only.
वही है कि सर जो वेंटिलेटर्स आ रहे हैं उसके साथ ये चीजें मिली।
हाँ ये सब मिली, कुछ ये खरीदना पड़ता है सर, ये वाला नेबुलाइजर का
पार्ट बस खरीदना पड़ता है।
हाँ पार्ट खरीदना पड़ता है, जो कनेक्शन है वेंटिलेटर का वो सर जो वायर निकला हुआ है वो वेंटिलेटर में जाके हाँ वो कनेक्ट हो जाता है, वो कनेक्ट हो जाता है।
जनरली ये वेंटिलेटर के साथ ही ज़्यादातर यूज हो रहा है, तो इसलिए जो है वेंटिलेटर के साथ मिल जाता है।
So moving towards the third question, the answer will be from this side. When a patient is being treated with an inhaled steroid, you should advise them to eat before the medication dose, drink before the medication dose, rinse their mouth after the medication dose? None of the above. Raise your hand.
Dr.
Dr. Rajeev Gupta sir. जो पहले हाथ उठा रहे हैं वो मैम पहले डिटेक्ट कर ले रही है शायद. डॉक्टर राजीव गुप्ता सर का आंसर है rinse their mouth after the medication dose. So is it the right answer? That's the right answer. Big round of applause for Dr. Rajeev Gupta sir. Yeah. So any rinsing material you are suggesting how to?
No, sir, just with normal water.
And after how?
Just after nebulization, just basically to prevent the oropharyngeal deposition of an inhaled steroid to prevent fungal infections. That's it.
So even in inpatient, you are supposed to rinse their mouth of your patient. So for the fourth question, we'll take the answers from this side. Raise your hand, just. The optimum time for bronchodilator nebulization is 2 minutes, 5 minutes, 10 and 20 minutes. Dr. Mahendra Gupta. Optimum time for bronchodilator nebulization is
10 minutes.
So we'll take the another answer from that side. Raise your hand. That's not the right answer. 10 minutes. So that's the right answer. 10 minutes. Big round of applause for Dr. Chaturvedi. So the timing of nebulization is also important. This is the last question. Which of the following nebulized antibiotics have a proven role in the management of chronic pseudomonas infection and respiratory disease? Is it tobramycin, gentamicin or colistin or all of the above? Raise your hand first. First raise your hand. Dr. Ashwini, tobramycin? That's not the right answer? Ma'am. Dr. Sanjeev Gupta has given the right answer. Big round of applause for Dr. Sanjeev. The correct answer is all of the above. The tobramycin, gentamicin and colistin. Dr. Vatsal will be happy to answer.
Sir, I haven't used it. No, sir, I am not aware. No, sir, I don't have.
सर आईवी यूज ही अभी क्वेश्चनेबल है नहीं तो इम्यूनाइजेशन का भी कोई रूल नहीं है मतलब कोई गाइडलाइन.
Yes, ma'am. N-acetylcysteine has a role wherever there is problem with there is very thick secretions, problem with ineffective expectoration. It can be used both in nebulized form, even in tablet form, and even in IV form.
So it is used along with any bronchodilator or alone?
Ideally, ma'am, a bronchodilation should be given before giving N-acetylcysteine.
Means any bronchodilator or Buticort?
Ma'am, Buticort is an inhaled steroid. So, ideally we should be using a bronchodilator such as a salbutamol. Ma'am, bronchodilation. No, sir, separately. The cycle of management in a bronchiectasis patient is an effective airway clearance, followed by a nebulized bronchodilator, nebulized N-acetylcysteine, and a nebulized antibiotic after that. Sir? Sir, we give it not more than 7 days to 10 days, 600 mg TDS with half glass of water. Sir?
Only 7 to 10 days.
So we give not more than that. If we have to give for prolonged period, we prefer nebulized it in nebulized form, especially to this patients with have difficulty in expectoration or something like that. So there is no role of mucolytics in acute attack of COPD. For bronchiectasis, these can be used.
At what pressure it goes?
Sir?
At what pressure this nebulized fluid goes?
Sir, the sir?
Pressure exerted by nebulizer
in atmospheric
एक
pressure.
लाख में था 2 लीटर से लेकर 10 लीटर।
वो हाँ वो फ्लो रेट का होता है सर कि आपका जैसे बहुत जगह आप वॉल माउंट में कनेक्ट करते हैं तो ऐसा नहीं है कि उसको 1 लीटर पे खोल दिया तो डिलीवरी होगी, कम से कम 5 लीटर पे उसको देना है तभी इफेक्टिव एरोसॉल बनेगा और मतलब वो हेल्प करेगा डिपॉजिट होने में। कंप्रेसर का प्रेशर का सर मैं बहुत श्योर नहीं हूँ, एग्जैक्ट प्रेशर क्या होता है उसका सर वो मुझे नहीं पता है। हाँ सर।
Just you discussed about the gene therapy. Is it gene therapy? Gene therapy.
No sir, no sir. It is just the ongoing research is in the phase of vaccine development and gene therapy, mesenchymal stem cell therapy. There are no proven role till now in this of nebulizers. And so there is no proven role. That is experimental studies. Experimental studies, sir.
How much drugs delivered by nebulization? If you are taking percentage, in percentage, how much percentage are?
Sir, 10% only.
10%.
10% only.
What are the drugs side effects of bronchodilators?
So bronchodilators, if we use, there is the side effects are tachycardia, palpitations, then tremors. These are the common side effects of beta agonist. So we have to reduce the dose. We have to be very cautious in patients. So that is the thing, in cardiac patients who are suffering from atrial fibrillation, we always try to avoid use of short-acting beta agonist and even long-acting beta agonist. There comes the role of SAMA, LAMA and ICS if indicated. We try to avoid the beta agonist as much as possible because they will precipitate tachycardia or atrial fibrillations and flutters.
For how long it will last?
Duration per se, so how long it will last? Mostly it settles by itself. Sir, without we can give just a stat dose of amiodarone and it usually settles by itself. If it
Patient become very panic when this occurs.
so at that time you have to stop, get an ECG done. If it is suggestive of atrial fibrillation, give a stot of 150 mg amiodarone stat over over 10 minutes in 100 ml NS. And if it does not settle, the rate can be repeated. Even if it does not settle, there is role of calcium channel blockers like diltiazem.
How many times we can nebulize in a day?
Sir, SABAs and SAMA can be given up to 6 to 8 times in a day. And when patient comes in acute attack, we give at 20 minutes interval until the dyspnea settles or patient's condition improves. At 20 minute intervals, 3 times mostly we give it.
And what in adults?
Sir, in adults also in a way we practice in emergency if the patient comes thrice at 20 minutes intervals. And after that, we give a trial of steroids. Steroids we mostly give at that time itself, especially in asthma patient. The treatment is SABA-SAMA plus an inhaled steroid in the form of budesonide.
So always is it nebulization machine is necessary, or at times people used to give nebulization through oxygen?
Sir, in asthma, it doesn't make a difference if you use with a jet nebulizer, with a compressor or a wall mount. But in COPD patients, we should always advocate the use of a compressor rather than oxygen because it increases the oxygen very high and there are chances of retention of carbon dioxide. So in COPD we keep the target of 88 to 92% saturation, and that can be done with the help of using a compressor, compressed nebulization rather than oxygen driven nebulization.
So there are some traditional nebulizing agents and there are some upcoming nebulizing agents. So what is your current regime of using in the very early acute exacerbation of COPD?
For acute exacerbation
what is
of
your regime?
For acute exacerbation of COPD, we give nebulization with SABA plus SAMA, that is ethylene plus ipravent, thrice at 20 minutes interval. We look for the response. Along with that, we give an inhaled IV hydrocortisone or mostly IV hydrocortisone 100 or 200 mg stat. After that, most of the patients improve. We have to shift them on triple inhaler therapy, that is a Foracort which consists of a LABA and ICS and a LAMA in the form of glycopyrronium which we keep for maintenance. And these patients who are very elderly and cannot take, they can even be discharged on this medication and followed up. When they get better, we can shift them, always try to shift them to pressurized meter dose inhaler with spacer.
What is the difference between salbutamol and levosalbutamol?
So there is a better, they say there is better size and better drug delivery with levosalbutamol, that is a newer molecule. Exact composition difference I also don't know, but levosalbutamol is slightly better compared to salbutamol.
Levolin in spite of alkaline.
Ma'am, can be used. Levolin.
Levoisomer of the salbutamol.
Levoisomer of the salbutamol. That is slightly more better than.
And what is salmeterol and formoterol?
So salmeterol and formoterol are long-acting beta agonist. Formoterol is rapid acting and long acting. Salmeterol is slow acting and long acting. We can remember why S is slow acting, F is fast acting. I remember it that way. Slow and fast acting wala.
Which one is better? Which is to be?
Sir, the most of the studies in asthma, GINA and GOLD guidelines have used formoterol as a drug along with budesonide. In practice per se, I prefer formoterol more compared to salmeterol.
which is the कम है पेशेंट का
सर
SpO2 कम है
हाँ सर
तो उसे ऑक्सीजन सिलोराइज करना चाहिए या मोटराइज सिलोराइज करना चाहिए
सर पेशेंट कौन सा है वो देखना चाहिए अगर एस्थमा का पेशेंट है आप हमेशा ऑक्सीजन ड्रिवन नेबुलाइजेशन दीजिए
एक्सेलरेशन और अस्थमा है
आप ऑक्सीजन ड्रिवन नेबुलाइजेशन करिए ऑक्सीजन ड्रिवन नेबुलाइजेशन
अस्थमा के पेशेंट में तो हमेशा अगर SpO2 नॉर्मल भी है तो भी आपको
ऑक्सीजन ड्रिवन नेबुलाइज
बोल रहे हैं कि वो मोटर जैसे काम करता अच्छा काम करता है
सर वो COPD के लिए बता COPD के लिए बता रहा हूँ सर
COPD में उसमें कार्बन डाइऑक्साइड रिटेंशन हो जाएगा ना ऑक्सीजन इज द ओनली ड्राइविंग फोर्स
हाँ hypoxia is the driving force for driving force to the chemoreceptors for मतलब breathing के लिए in a way deep breathing.
So what is your preferred steroid? At times people use methylprednisolone and hydrocortisone. Which one do you prefer is the
Sir, I prefer using hydrocortisone. Per se, it is most fast acting.
What doses are you using?
For acute attack, we give 100 mg or 200 mg stat. If patient is on ventilator or on NIV using HFNC, we go with 100 mg TDS. And if a patient is on OPD basis, can take orally well, we go with 30 mg of prednisolone.
Any other questions?
Since you start antibiotic during nebulization?
Ma'am, in asthma patient, there is no need of nebulized antibiotics. Most of the asthma attacks are due to acute viral infection. The mainstay of treatment is an inhaled corticosteroid along with a long-acting beta agonist, along with SOS use of SABA and SAMA, and a short course of steroids. Antibiotics per se, until you don't find a source of infection in the form of high-grade fever or expectoration or elevated TLC, better to avoid antibiotics in asthma. But in COPD, antibiotics have a proven definite role and has a role in mortality reduction also in acute attack of COPD.
Any other question?
Question here, at present in guidelines, which diagnosis you prefer inhaled antibiotics? मतलब गाइडलाइन में किस
गाइडलाइन के हिसाब से आप कौन सी
मतलब जैसे इतना डिस्कशन होने के बाद जो नेबुलाइजर है साबा ये सब तो गाइडलाइंस में है लेकिन एंटीबायोटिक्स की गाइडलाइन बहुत डिलेमा में
सर सेपरेट गाइडलाइंस कोई भी एंटीबायोटिक्स की नहीं है
जो ट्रीटमेंट हम करते हैं जैसे निमोनिया का ट्रीटमेंट तो निमोनिया के ट्रीटमेंट में किसी गाइडलाइन ने किस लेवल पे इंडिकेशन दिया है कि इसको आप देना है
सर
इनहेल्ड के रूप में आईवी नहीं
किसी भी सर गाइडलाइन में
ऐसे ब्रोंकाइटिस में तो रोल क्लियर
रोल डेफिनेट रोल है COPD में भी सर अगर क्रोनिक स्यूडोमोनास कोलोनाइजेशन
आप कब लगवाते हैं ये
सर जैसे कि ब्रोंकाइटिस पेशेंट में स्यूडोमोनास का कोलोनाइजेशन आ गया सर 28 डेज ऑफ टोब्रामाइसिन इज अ स्टार्ट ट्रीटमेंट डोज COPD पेशेंट्स यहाँ पे नहीं लेकिन जब मैं VP चेस्ट में था वहाँ पे क्योंकि क्रोनिक एयरवे वाले आते थे स्यूडोमोनास कोलोनाइजेशन आ रहा है हर महीने में 2 बार उसको एंटीबायोटिक्स लेनी पड़ रही है तो 28 डेज ऑफ टोब्रामाइसिन इज अ गुड चॉइस आई inhaled tobramycin 28 days 300 mg BD and for ICU में at times when non-pseudomonas colonization of bronchiectasis है there is a role of IV nebulized plus IV colistin therapy 1 MIU TDS.
What is the role of antifungal in?
Sir, antifungal per se I have not used. There is in literature there is given role of amphotericin B, but I haven't used it per se. But in PCP pneumonia, when Septran cannot be given, inhaled pentamidine is a very good option. 300 mg, 300 mg BD, something like that.
What is the current role of injectable aminophylline? Are you using it?
Not using it here, sir. There is a lot of side effects, and till now in BP chest we used to use aminophylline infusion, but in ICU setup under continuous cardiac monitoring, in current practice we try to avoid as much as possible, because before that we have so many options which we can use in practice before giving IVM.
Like what is the like?
Matlab we have bronchodilators, we have inhaled corticosteroids, we have.
Patients are very resistant. They are not responding to anything. So
At times we have used it, sir, but here I haven't used it. Even in AIMS also we did not use aminophylline there for last 3-4 years. Yes, sir.
And the role of anti-allergies and conjunctivitis.
Ma'am, bronchial asthma, we have seen patient using Montelukast for 5 years, 6 years, 7 years, and they say that whenever they stop it, they have dyspnea or they have cough. But even in the GINA guidelines for asthma, Montelukast is never a first line treatment for asthma. It is an alternative option only. So if a child who can take a pressurized metered dose inhaler or a DPI, always give a trial of LABA ICS first or an inhaled corticosteroid itself. That many times that can stop, he can get overcome of Montelukast. What I do is at times who are patient taking from 6 to 7 years, I start them on ICS and ask them to gradually reduce the dose of Montelukast. Take it alternate day, 3-4 days, 5 days, because they have been using from 6 to 7 years that drug. So in literature, it says that Montelukast is associated with neuropsychiatric effects, but per se I haven't seen any patient suffering from that.
I think we have come to the end of this quiz session. A big round of applause for yourself and Dr. Vatsal.
At present, oral लाबा का कोई रोल है कि नहीं है, क्योंकि ये बहुत इम्पोर्टेंट है कि सबके पास जो पेशेंट आ रहे हैं.
There is no role of oral salbutamol in any guidelines.
और लॉन्ग एक्टिंग एक बीच में आया था बॉम्बेट्रॉल करके सकता है.
सर बॉम्बेट्रॉल तो नहीं यूज किया मैंने सर. मोस्ट ऑफ
जैसे अब मैंने देखा ओरल का प्रिस्क्रिप्शन भी अभी आने लगे हैं. मैं नहीं कह रहा हूँ रिकमेंडेड है, लेकिन जो फिजिशियन के लोग एस्पिरिन यूज होता है,
टैबलेट एस्थेलिन,
वो रिकमेंडेड नहीं है
सर.
किसी गाइडलाइन. ओरल का कोई रोल नहीं है सीओपीडी अस्थमा में. इनहेल्ड.
So I think it's time for certificate distribution.
जैसे जो हम कोविड टाइम में ऑक्सीजन पंपिंग सिखा रहे थे, व्हाट इज द रोल ऑफ दैट ऑक्सीजन पंपिंग जो ऐसे करके बताओ पेशेंट्स को योगा करके.
मैम एक तरह से अगर आपके एल्वेलाई को खोलने में हेल्प कर रहे हैं तो ठीक ही है. हम प्रोन पोजीशन भी इसीलिए कराते हैं कि आपके एल्वेलाई ज़्यादा ओपन अप हो जाए. तो एक तरह से मॉडरेट हाइपोक्सिया में इवन जब सिवियर एआरडीएस हो जाता है, पीएफ रेशियो बहुत कम हो जाता है, पेशेंट को प्रोन पोजीशन वेंटिलेशन कराते हैं. उसका मेन पर्पस ये होता है कि आपके एल्वेलाई थोड़ा खुल जाए और ऑक्सीजनेशन इंप्रूव हो.
Postural drainage was very common.
Yes, sir.
What is your opinion about this?
Sir, depending upon where we always for the COPD patient, rather than medications, we first send patient for airway clearance techniques, which comprises even of postural drainage. That is the first line treatment in a COPD patient. It is used even now. We have a definite fixed chest physiotherapy department who teaches the patient of postural drainage and gravity assisted drainage.